We start with pallor today. Pallor is a very interesting topic. I found it very interesting when I was a lecturer in RG Corps and a baby was admitted with pallor and he received about 18 units of transfusion. And after that, we discovered that he had malignancy. Malignancy was diagnosed by a bone marrow examination. It is just by God's grace that the child gave us the chance to transfuse those 18 units in 1.5 years. And he survived to go to the diagnosis and the therapy. And after the therapy, he survived. This whole process, that is giving the PRBC, surviving him till the diagnosis we reached to, and then treating him, it's just by God's grace. So pallor is a very interesting topic. I want to start with it because we know that general survey, we start with pallor. Pallor is a symptom and sign which is seen in children only in palms and soles by according to WHO bulletin. WHO bulletin has told us that you are not to look at the conjunctiva in children because conjunctiva is often affected by vitamin A deficiency and glossitis, that is the cheilosis and the glossitis caused by vitamin B deficiency. It interferes with pallor assessment in the tongue. So instead, we see the pallor of the palms and the soles. You can see the pallor of the palms and the soles and compare it with your own because the doctors are usually well fed and so they have much more blood than the patients. In our country, we have two sets of patients. One is urban, the other is rural. The urban people are better fed because they are the haves and the 15%, 85% is in the rural and the 15% get the haves. They get the nutrition from the green vegetables, from the red vegetables and from the proteins that is available in the market. But the rural people do not get it. In addition to that, they walk along the fields bare feet. And you know, hookworm anemia, it enters through the feet, bare feet of the children. So we have to be very cautious when we are treating children right from the newborn period. Why? Because the newborn has fetal hemoglobin and it is replaced by adult hemoglobin after the first oxygen rushes into the lungs. This takes about 6 months, that is, adult to fetal hemoglobin proportion is 90-10 at birth, then it is 70-30, and finally completely replaced with adult hemoglobin. Now, this change needs a lot of hemolysis. The RBCs are broken down and jaundice, physiological jaundice and physiological anemia of infancy, it appears around the 6 to 9 months of age because there is a product in breast milk. The breastfed babies, we know exclusive breastfeeding is recommended for the first 6 months of life. If you continue it till 2 years or 5 years, according to WHO, the growth of the child is always better, in addition to the complementary feed which is added at 6 months. Now, what happens in this age, this adult hemoglobin and this fetal hemoglobin, they have a contradiction to each other. That is, the adult hemoglobin gives more of oxygen to the tissues, whereas the fetal hemoglobin, it gives less oxygen to the tissues. So a baby who's suffering from hemolytic anemia, that is the breakage of RBC, that is the fetal hemoglobin, it persists after birth instead of being replaced by adult hemoglobin, that is hemolytic anemia. Acute hemolysis causes acute pallor, that is caused by G6PD deficiency, by hemolysis due to thalassemia or the hemoglobinopathies, and iron deficiency anemia are important factors which are causes of pallor in our country. So in our country, breast milk, I told you, contains lactoferrin, which makes the hemoglobin more bioavailable to the baby. And obviously, iron deficiency anemia does not appear before 6 months of age. It appears at 9 months to 1 year because lactoferrin is there in the breast milk to save the baby from iron deficiency anemia. Lactoferrin. Very important thing. So when you say that you're exclusively breastfeeding the child, number one is colostrum. Colostrum contains secretory IgA, which gives immunodeficiency to the nasal and the GI tract for life. For life. Nasal and GI tract for life. In addition to that, lactoferrin is present in breast milk, in mature breast milk, which gives protection from iron deficiency anemia. In addition to this, after 1 year, the baby learns to walk. And with walking with a broad base, a toddler who balances himself on his arms and legs, his feet are wide apart, walking like Romans. That toddler walks usually bare feet, both in home and outside. Whenever he goes to the fields, he's more prone to hookworm anemia, which enters through his feet. So, whenever you see a 1 year old or a 2 year old, you should tell the mother prevention of anemia is done by using covered shoes, that is, covered shoes for the legs, for even for rural, very poor people, they can buy kids for the babies. Kids, we have for sports, we use kids in schools. Those kids are available in printed cloth for babies. Those covered shoes are enough to protect the baby against hookworm anemia. Hookworm anemia is one. And what happens? The hookworm enters through the feet, and then it will go to the blood and to the GI tract, and the hookworm will attach itself through its trident mouth, and it will keep sucking blood, and it will cause severe iron deficiency anemia. In addition to these helminths, hookworm, there are other roundworm and pinworm, and these are there. Orophycal root, which goes from one brother or sister who goes to school, gets it from his friends, and brings it back to the house to infect his other sib. So whenever you treat anemia, iron deficiency anemia, you give the anthelmintics to the whole family, that is the mother and the father and the children. You give iron to the family, that is to the sibs and to the parents too. Because as the baby grows up, other factors are there to increase this anemia. What are these other factors? Number one, I told you, for a toddler, he might present with decreasing hemoglobin in the first 6 months or 1 year of life, and that may go down to 6 or 7. I can tell you of an incident, very important incident. One doctor and his wife, when I was in BC Roy Children, our superintendent, his brother's daughter was studying in Bakura Medical College. She got married to a doctor. They were not screened for thalassemia. And when they got a baby, suddenly they saw the hemoglobin was going down at 6 to 8 months of age. And then they found out by HPLC that the baby is suffering from thalassemia. This is a very sad thing. And that boy, that Bakura doctor, he just resigned from health service. He went to the UK or the USA, I don't remember now which country he went to get his bone marrow stem cell treatment, to get it done, to get the marrow to cure the child. That is the only treatment, curative treatment of thalassemia. Another treatment is there for thalassemics, which you can do as doctors when you grow up. Supposing a school child, that is an adolescent child, that is a 10 or 11 or say a 17, 18-year-old is friendly with another of the other sex. What you do is, supposing they get a thalassemic carrier, one heterozygous and one heterozygous mother and another heterozygous father have to copulate to give rise to a thalassemic child, that is a homozygous child. That is, two heterozygotes gives rise to a homozygote, that is a thalassemic child. They have 4 children. It is 1 in 25%, that is 1/4 of the children are affected. Another child is normal and 2 are carriers. So, if you introduce this introduction of screening of the blood that is only the hemoglobin A2, you need to see if it is more than 3.5. Supposing it is 5 grams per DL in a normal adolescent or young adult in school or college, that child should be told to get his opposite sex, whoever he is friendly with, opposite or maybe the same sex now, to screen himself or herself for thalassemia. This is an important thing which has to be done. In addition, a thalassemic mother who is a mother of a thalassemic child who is admitted in a hospital, you tell that mother if she is pregnant the second time, she can have amniocentesis done and a chorionic villus examination. See chorionic villus examination at 12 to 16 weeks of age. This is done by very few thalassemic clinics. One is Medical College, Calcutta. Another, we are trying to make it throughout West Bengal. That because this is a belt of thalassemia, this whole belt, even in Punjab, there's a belt of thalassemics. So to stop the cycle of thalassemia, what you tell is, you tell the mother that when you conceive your second child, you get yourself screened by chorionic villus sampling at 12 to 16 weeks. And if necessary, you can abort the child. If the baby is thalassemic, you abort the child. If the baby is normal or a carrier, you can carry on the pregnancy. And the carriers, if they don't get married to a heterozygous, they will never get thalassemia. And the normal is normal for life. This is the transmission of thalassemia. So this is very, very useful for thalassemics. Now I will come to the other causes of iron deficiency anemia, which is, I told you, Hellman's. I told you to family treat the whole family, give iron to the family. That is another cause. There is another cause, G6PD deficiency. I told you. G6PD deficiency is precipitated by few drugs. I will tell you the names of the drugs. Supposing you get a G6PD deficiency, a baby with acute severe pallor, at any age, the baby has the new neocytes, that is the bone marrow is always bringing up neoblasts, that is new RBCs, as soon as hemorrhage occurs. Supposing hemorrhage occurs or blood loss occurs through the GI tract, microscopic blood loss, that is, you cannot see it, like portal hypertension, you get hemorrhoids, you cannot see that blood, or piles, you cannot see that blood, but you get melena or you get gastric hemorrhage, anything like that, then what you do is, the marrow will always try to compensate by making new RBCs which are not so much deficient in G6PD. So you have to repeat this G6PD deficiency after 3 weeks of the acute attack. Supposing a paracetamol or an anti-malarial or an anticonvulsant, it causes a G6PD deficiency. I got a baby who had his grandparents' dapsone for leprosy. He was having dapsone. And that baby took those grandfather's dapsone, thinking that they are lozenges. And he appeared to the emergency with severe central cyanosis and acute pallor. Now, methemoglobinemia, how do you treat it? It was 1985. It was not present in the books of Nelson. Nelson books were not available then. We used to read pediatrics from Achar, S.T. Achar, Tropical Pediatrics, Manson and Barr, Pathology. So what I did was, my boss told me, in order to finish your MD, to be successful, you have to save this child. And he went away. What I did was, I did forced alkaline diuresis. Methemoglobinemia is there in the... Methemoglobinemia does not occur unless and until the hemoglobin is 5 grams per cent. Does not occur. So what I did was, I used bottles of saline to do forced alkaline diuresis, and soon the baby got rid of those dapsone in his blood, and together with that, the G6PD deficiency was also gone. This is how the reticulocytes behave. The reticulocytes and the RDW are very important factors in hemolytic anemia, because in thalassemia, you give different sizes of the RBCs. So different sizes of the RBCs means the diameter of the RBCs are more or short. So the RDW will increase. Reticulocytes will increase in hemolytic anemia. Whereas in iron deficiency anemia, iron is not present in the iron stores of the body, that is the bone marrow and the sternum or the bone marrow. It is not present in the stores, so the reticulocytes cannot be formed. Reticulocyte is low. Reticulocyte being low, serum ferritin being low, reticulocytes being high, serum ferritin being high differentiates iron deficiency anemia from hemolytic anemia. In addition to this, there is an anemia of chronic infection. Chronic infection, that is plumbism. You know, the babies have pica. Pica is altered appetite. They can lick the paint of the doors and the windows, and they can get chronic plumbism, that is lead poisoning. Lead poisoning also causes microcytic hypochromic anemia. And microcytic hypochromic anemia, lead poisoning, it can be seen in the RBCs, in the morphology of the RBCs. Microcytic hypochromic anemia get in both in iron deficiency, hemolytic anemia, plumbism. In all three, you get microcytic hypochromic anemia. Macrocytic you get where? In B12 and folic acid deficiency. That is present in other cases. I will discuss that later. First, you have to differentiate this plumbism. You have to do the lead deficiency. Plumbism, plumbism means lead is excessively present in the blood. There is ceruloplasmin deficiency also causes anemia. Ceruloplasmin deficiency causes case of Fleischer ring in the iris, eye examination, copper, that is copper, lead. These are important minerals which you should give importance to in pediatrics, because one causes plumbism, that is lead poisoning, other causes copper deficiency, that is ceruloplasmin deficiency, that causes other diseases in children. So I think iron deficiency anemia we have almost covered, almost all. I have to look at my book for the extra. Oh, okay. So the deficiency of chronic infection, which I said, you get in tuberculosis. Tuberculosis is a very chronic infection. It comes from the open case of sputum positive infection in the adult, and it comes from the adult to the newborn or the child within 3 feet distance, and then it forms a Ghon's focus in the subpleural space, in the pleura, in the lungs. From you cannot see it. Subpleural focus is not visible in the lungs. You can see only the lymphangitis, that is the draining lymph nodes, and the hilar lymph nodes is visible on radiology. So primary tuberculosis can cause anemia. There are several diseases, tuberculosis, sarcoidosis, etc., etc. These cause serum ferritin, which is 200 to 300, neither low like iron deficiency anemia, neither high like hemolytic anemia. I think with this we can end Pallor.